Good evening, and I welcome you all to the second CPD session of this month, organized by Sri Lanka College of Specialist Family Physicians. Today, our resource person is Dr. Nishan Vas Gunawardhana, consultant interventional cardiologist of Provincial General Hospital, Polonnaruwa. If I describe about him, Dr. Nishan obtained his MBBS from the Faculty of Medicine, Colombo, and he obtained his MD from the Postgraduate Institute of Medicine of Colombo. He is also AMC qualified and MRCP UK qualified. So today's his session would be on ECGs, which would be a great benefit and great advantage for us as primary care physicians, because ECGs is a part and parcel of our practice as primary care physicians. So I hope you will get this opportunity and you will use this opportunity to learn about the things Dr. Nishan is going to teach us. So before we begin today's session, let me remind you about the housekeeping rules. Please keep your mics muted. If you have any questions, you can forward it to the chat box, or you can unmute and forward the question. But if you are not talking, please keep your mics muted. And at the end of the session, we will be sharing a Google form with some MCQs. You have to fill this to obtain the CPD certificate, which provides 1 CBT point. And to obtain the certificate, you have to remain in the program at least 45 minutes. So with that, I would like to hand over the mic to Dr. Nishan.
You understand what I tell. So within the first 4 hours, you can have false negatives where it is negative, but actually there is a MI because it has not reached the capture level of the assay. So there are problems with each of these answers, but I'm glad that your first answer, if you have the facility, take the ECG in the correct way. But if you don't have the facility, I would suggest strongly in this patient for you to transfer the patient to a facility which has a ECG. Then let's move on. So this is the ECG. This is the ECG, first ECG. So can anyone comment on this, or shall I proceed? Can you see anything significant? All right. Super. Shall I proceed?
Yes, sir. There are no answers in the chat box.
Okay.
Somebody has mentioned J point elevation.
Okay, good. So if you closely see, the only striking abnormality here is the T-wave inversion where my laser pointer is on the AVL. Can you see that?
Yes, sir.
Right. And there is a bit of a hyperacute T on the inferior leads. Can you see 2, 3 AVF? A bit of a hyperacute T.
Yes.
I will tell you what I mean by hyperacute T later. But there is no obvious ST elevations to be noted here. So then a practitioner might think that there is no myocardial infarction because there is no significant changes. But you should always make it a point, if the history and examination is suggestive, you should always repeat the ECG in half an hour's time. So this is the ECG when it was done half an hour later. Can you see the marked difference?
Yes.
So if you have stopped at this stage and treated it as gastritis alone, or just send the patient home, you would have missed a complete ST elevation MI. So the important point here is to have a hawk-eye to capture this slight hyperacute T. So when you repeat the ECG in 30 minutes, you always capture it. So my take-home message is, if you have a patient who you suspect myocardial infarction, always don't stop at the first ECG if it's not obvious frank changes, but always repeat the ECG to see for any dynamic changes. So here you can definitely see the inferior is 2, 3, 4, 2, 3 AVF, ST elevation plus reciprocal changes of ST depressions in V2, V3 and 1 AVF. So in this slide, I have pointed what I mean by hyperacute T waves. Can you see here? This is the hyperacute T wave. So the hyperacute T wave means from the J point, as someone correctly pointed, the J point itself has a slanting upward stroke ST segment. So the ST segment is slanting upwards to a T wave. Usually it should be horizontal like this. Sometimes people tend to mistake with having hyperacute T waves with hyperkalemic T waves. Hyperkalemic T waves on the other hand has a flat ST segment. The ST segment is flat. It is not upsloping as in the hyperacute. I hope you are clear on the differences between ischemic hyperacute T wave and hyperkalemic T waves.
Yes, sir.
Super? Yeah.
Yeah.
Good. Right. So this patient has an inferior ST elevation MR. So further going on to, I can remember when I was learning in medical student days, and Prabhat was in the same batch, ironically. So our teachers used to tell that cardiac pain is referred to the front of chest, which radiates to the left jaw, neck, and left arm, and it's associated with autonomic symptoms. It is felt like an elephant crushing on your chest, and you have a peculiar feeling of impending doom, which we call angoenemy. I think you have heard this sentence over and over again, the description of an angina. But angina is not that simple. After working in government sector for now as a consultant, I have been working for 4 years. We come across patients which have the most peculiar type of chest pains. So this is a nice diagram to show where the chest pains can be. Now the patient we discussed, the pain was here at the epigastric. But in general, if I say, if any pain from abdomen to neck on any side of the body, it should not be on the left arm, it could be on the right arm. Any side of the body from inguinal ligament to the neck, it could be a myocardial infarction. But the diagnosis depends on your holistic approach and how you approach to the history as well as the overall picture. So if someone has a right inside arm pain, it should not be neglected as not having MI for sure. But you always go on by these features: location, character, duration, relationship to exertion, and exacerbation relief factors. I'm sure you all have a good training of history taking in your medical student days as well as your MD training regarding these points. So you must have heard of typical angina, atypical angina, and non-angina chest pains. It's a common scenario. So there are definitions for this. So when you use the term atypical angina, you have only 2 out of these 3. So remember these 3. First is constricting discomfort in the front of chest. Second is precipitated by physical exertion. Third is relieved by rest. So most of the time cardiac pain is on exertion. Later on, patient get rest pain, but initially it's exertional and it's worsened by exertion. The definition of unstable angina. For definition, I would say unstable angina is an angina which has recently worsened, but the troponin assay is negative. So there is no identifiable myocardial damage biochemically, from the biomarkers point of view, but there are ECG changes. There is suggestive chest pain. So what we discuss is an inferior ST elevation MI, but there could be other types of MIs. If you, for example, if it's a lady, a left anterior descending artery territory, we call it anterior ST elevation MI. So ST elevation would be V1 to V5. If it involves lateral branches, V5, V6 plus 1 AVL would get affected. Then you have this type of distribution. So I don't expect you all to identify every ST elevation, but ST elevation is something which should not be missed. Right. After telling all this, we come to an interactive session. So I want someone to type in the chat. This patient, 55-year-old, coming with classical angina for 2 hours duration. ECG, first one is this. What's your answer?
People are typing extensive anterior MI, anterolateral MI.
Okay. So, yeah, I can see answers. Yeah, very good. So there is a big enthusiasm to answer that. That's something I didn't expect. Very good. Yeah. So if you see here, you can see definite ST elevations V1 onwards up to V6 and a slight ST elevation on 1 AVL. And there is reciprocal ST depressions on inferior leads. So when you have V1 to V6 plus 1 AVL, it's either called extensive anterior or anterolateral ST elevation. So you can use both words. Either is acceptable, but the main thing is that you pick up the ST elevation. Good. I'm trying to move to the next one. Yeah, this is the next one. Again, 65-year-old patient, classical angina, autonomic symptoms, pain duration of 4 hours. Please type in your answers on the chat box.
There's one answer, high lateral STEMI.
Yeah, so without further ado, I'll take into that. So what we can see is a clear ST elevation on 1 AVL. There's a hyperacute ST, what I showed you earlier, hyperacute ST on V5-6. So there is reciprocal depressions on 3 AVF. So it's a developing lateral STEMI. So high lateral, perfectly acceptable answer. But it will go on for a lateral STEMI because V5, V6 is already having a hyperacute T. That means in the next ECG, they will develop ST elevation. So what is the treatment, guys? What's the treatment for ST elevation MI? Primary PCI, thrombolysis, enoxaparin. Out of those three, what would you select? Primary PCI, first one, thrombolysis, tenecteplase, or enoxaparin?
Primary PCI is the most common answer given by the
Yeah.
participants.
You know what? I'm very happy. I'm working in one of the primary PCI centers. We provide primary PCI service 24/7, 365 days. And it's one of the 3 Sri Lankan centers to provide 24 hours work. So I'm extremely happy that you answered primary PCI. That's what we want. So I get around 5 to 6 patients per day for primary PCI from the region. My region is quite vast, so it receives patients from 6 districts, including Batticaloa, Trincomalee, from Dambulla onwards, Ampara, Monaragala. So we see primary PCI every day, but it's one of the most rewarding experience to treat a primary PCI patients rather unconscious or in significant pain, and he walks within the next 2 hours. So that's some satisfaction you can get from nothing else. Right. So the next. Sorry, the slides moving slightly slower. Can you hear me, Supun?
Yes, sir, we can hear you. If you maybe double click, it might.
Yeah, I'm doing all sort of things.
Yeah, I think with the here, of course, in my region, with the weather, there are some connectivity issues.
Okay.
I thought that's why the
All
speeds
right.
are
Right.
higher.
Suddenly it decides to work somehow. Right.
Yes.
Okay. The next question, the next answer from the knowledge I have translated to you as well as what we have discussed. A 45-year-old patient comes with 3 hours of duration chest pain, classic angina for 2 hours, for 3 hours. What's the answer, guys?
Inferior MI is the commonest answers.
Inferior stimulation
Inferior
MI?
ST MI. Yes.
All right. Thanks. There are 2 other things in addition to inferior stimulation MI here. Can someone point out those two? Those are complications of inferior stimulation MI. If you see very closely, can you see? Take your time. It's important.
අපිට අපිට එයාට දන්නේ ඇයි මේ ගැන මම නම්බර තිබ්බ ඩේටා ටිකක් තියෙනවා
Yeah, someone. Yeah, people have commented that there is hard blocks. So that's quite important. It's a complete hard block. And can you also see a posterior extension? So when you see told R waves in V1 to V3 with a ST depression, along with the inferior, you should suspect posterior extension of infarct, which you usually don't see in the normal leads. But when you take V7, V8, V9 leads, you will see a nice ST elevation. So when the mirror images V1 to V3 have a ST depression with a prominent R, but I'm quite happy people picked up the complete hard block where there is dissociation of PQRS ratios. So the P waves go at a particular rate and QRS go at a particular rate. Super clear?
Yes, sir.
Good. Right. I'm again trying to move. Right. Now we discuss one case. Now this is the second case. This is now I rather go out of the myocardial infarction parts. So it's not only myocardial infarctions you come across all day, but it's the most important. That's why I spend some time on them. But as cardiologists as well as primary physicians, you guys come across various other cardiac conditions. So one of them is patients on electrical devices, what we call cardiac implanted electrical devices, which could be permanent pacemakers, though defibrillators, or resynchronous therapies, CRTs, we call cardiac resynchronizations. So this patient, 76-year-old, permanent pacemaker done 10 years ago, he comes with frequent fainting attacks for the last 2 weeks. On examination, the pulse is irregular, blood pressure is fine, and ECG is this. What do you think? He was on pacemaker. So I have given 5 answers. Chest X-ray to check lead position, 24-hour Holter study to check for 6 sinus. Apply a magneto pacemaker. Urgent programming session after IV atropine bolus. Admit to cardiology department by it. What's the commonest answer?
Up to now, 4 and 5 are the commonest answer. I mean, 2 answers were given.
Good.
4 and 5.
All right. It's always easy to send to the cardiologist, isn't it? Yeah, I mean, it's easy way out. So admit to cardiology department by ETU is the easy way out and the safe method. Urgent programming session if you have the programmers. But not many centers do have that. And specifically at the primary setting, you don't have that capability. So what can you see? Usually, the implanted pacemakers only work for bradycardias. So the first theory is they don't work for tachycardia. So what they do is they are on-demand batteries. What I mean by on-demand is when the heart rate drops below a certain program level, which we call the base rate, it starts to fire. So here you can clearly see, in spite of there being no QRS complexes, it has not fired at all. So there is some malfunction of the device. But after some time, the own rhythm of the patient comes to the rescue. That's why he is not dead. If this continues, he will be dead. So there are 3 things: failure to capture, failure to pace, and failure to sense. So failure to capture means the pacemaker has generated the pacing stimulus. Can you see this marker? So that marker comes when there is a pacing stimulus given by the pacemaker, but it has not led to a QRS. But here, failure to pace means the pacing spike has not come at all. So there is no spike here. Failure to sense means, for example, when there is a native QRS here, you shouldn't try to pace the next few seconds because there's a good rate native rhythm. So you shouldn't try to pace if the programming is fine. But here, because of sensing issues, the pacemaker don't see this QRS. So it tries to pace with the erroneous timing. But it does not result to QRS. So can you see the 3 types of errors which a pacemaker can do? So
yes,
this one was what? Now, please type in your chat: failure to sense, failure to pace, or failure to capture. I think you all agree that there is no pacing stimulus seen. There is no markers here. So without pacing stimulus, there is no way that QRS complexes come up. So that means there is a failure to pace. It's similar to this. Similar to this. Okay, so the ventricle is in a standstill. There is a ventricular standstill due to failure to pace. Clear? Now here, in this example, can you see the pacing stimulus has come through, but it has not led to a QRS. That means failure to capture. Are you clear on those two scenarios, Supun?
Yes, sir.
Good. So I want you to highlight, I want you to understand what are the differences. So what to do? So what has happened is actually this pacemaker was put 10 years ago. Usual lifetime of a pacemaker is 7 to 10 years depending on the use of the patient. So this particular pacemaker has gone out of battery because he has not attended pacemaker programming sessions. Without his notice, it has come to end of service. So basically he needs urgent programming session as well as a new pacemaker battery. That means he doesn't need new leads, but just the battery. But until that time, we would manage him on a temporary pacemaker because otherwise he would have syncope. Case 3. 17-year-old girl with episodes of paroxysmal palpitation during sports, 1 episode of syncope, and her ECG is this. During palpitation episode, her ECG is this. We ask him what to do. Can you see anything? You are open to type in the chat box. If you see anything, adjust the answer diagnosis.
There are two answers, sir. One SVT, then WPW, and someone has typed NRT. The commonest answer is SVT.
All right. So,
And
yeah, I need to give a small clue here because traditionally, mark my word, the commonest narrow complex tachycardia you see is SVT, but SVT is 99% of the time do not have identifiable P waves. So can you see P waves here? So when P waves are there, it's either sinus tachycardia, atrial tachycardia, or sinus with aberrant conduction. SVTs classically do not have the P. So here you can definitely see the P, but if you see closely, specifically in lead 2 here on the rhythm strip, can you see that the PR interval is very short? Basically, there is no PR segment. At the end of P, QRS starts, and there's a bit of a slurred upstroke on the QRS. Can you identify those features? Chopur?
yes, sir.
Yeah. So, as someone correctly pointed, it's suggestive of Wolff-Parkinson-White. Wolff-Parkinson-White tachycardia. Right. So, how do you treat these patients is up to the cardiologist, but what I want you to do is to pick up those patients. So, if patient is symptomatic, like in our patient we discussed, definitely patient should be offered electrophysiology study. I'm fortunate to be trained in electrophysiology parts also. That's why I'm discussing these scenarios. So what we do is we put sensing sheets through the leg. So without open heart surgery, you do percutaneous intervention from the right femoral vein, where we send some catheters to the right side of the heart or the left side of the heart, depending on where the Wolff-Parkinson-White pathway is. And then we give radio frequency energy and just ablate the abnormal pathway. කියන්නේ එතන පොඩක් heat කරලා පුච්චනවා. When you do that, you completely take away the pathway, and then you allow normal conduction through the AV node, and it's a very rewarding process. It takes only probably an hour or so, and it's curative, 100% curative most of the time. This is the dreadful scenario where sometimes Wolff-Parkinson White patients go into one-to-one VF and VT, where the pathway is very fast, and if there is a SVT or AF, it allows conduction from A to V at the same rate, and patient can have sudden cardiac arrest. So this type of ECG is classical of WPW one-to-one conduction down the path.
Right. So I explained that this 80-year-old patient. Right. I move to the next one. Again, bit slow to move. Right. So 35-year-old, recent viral fever, comes with shortness of breath, and atypical chest pain. I think it's a common scenario for you all. So what would you do next? You can read the 5 answers and then give an answer on the chat box.
People are answering as number 5 said, well, lead ECG to check for myopericarditis.
Right, good. Since a cardiologist is presenting, probably, right? Otherwise, most would have, I think, gone for number 1. Right, but that's also important. You have to symptom relief, but 12 ECG is important. So this is a classical myopericarditis ECG, where we can see concave ST elevations, and there is a PR segment depression. Hope you can see the image.
Yes, sir.
One important thing is, compared to the previous ST elevations we showed, here there is no reciprocal changes. So even though you are not sure of the concave pattern, still you can go by absent reciprocal changes. And on the echo, you have various features which I don't want to discuss, but by the ECG, you can get the diagnosis. This next case, a young boy comes with atypical chest pain and disease spells. Anyone wants to answer? What's the diagnosis on the ECG?
Someone has answered Brugada.
Right.
Brugada syndrome.
Very good. Right. So I'm happy that you can identify the Brugada. This is a classical type 1. So how do you diagnose Brugada is, let me go to the next slide. Right. So there are 4 features. One is a broad P wave. Second is J point elevation here. Then this ST pattern is classical. We call it cove-like ST segment. And a terminal T wave inversion. So that's the classical Brugada. Right. Next case is something we come across day to day. A rhythm abnormality. What's the diagnosis here? So this patient, let's say, comes with palpitations for 2 months. Any answers on the chat box?
Not poses is the answer. One answer, poses.
Okay.
Flow AF.
All right. Right.
Yeah.
That's the answer. Right. Once I get the first correct answer, we'll stop the chat. Right. So you can see that there is no clear P waves. There is no P waves clearly. Let me take the laser. So these are fibrillatory waves. So those are not P waves, and the RR is irregular. So it's a classical atrial fibrillation and a bit of a slow one. Here the heart rate has been 32. So that's something you should not miss. Now, Prabhat wanted me to speak on acute coronary mimics as well as early events. So this is something we come across. Where patients come with chest pain, angina, but they have this biphasic ST segment on V1 to V3. Anyone knows what we call it?
Valence ECG is the
Yeah, very good. You guys can do cardiology for sure. So valence pattern is a predecessor. ST elevation is the next step of this. So when you see valence, there is no guideline recommendation to thrombolize, but we have to take it as a very high risk STEMI, where there could be ST elevation at any moment. So generally, I take to the cath lab within 24 hours. But it does not need to be in the first 12 hours. Classically, it is due to a floating thrombus in the proximal LAD, which is on and off letting some blood go down the line, but sometimes blocking. That's why it creates the biphase. I hope people are not sleepy. Can I continue for 10 minutes more?
Yes, sir. Please. We are still having the participation of more than 160, sir.
Lovely. Without even seeing me, no?
Yes, sir. Just for your voice, even.
we lost it for 10 minutes. Trying to move to the next case. So this is valence. I'm sure you are. Right, this is interesting one. 74-year-old, recent diabetic foot amputation, comes with atypical angina and acute shortness of breath and marginally low blood pressure. Anyone with a diagnosis?
Pulmonary embolism is one answer.
Yeah, very good. Right. So the history gives the clue. Diabetic foot amputation. That means patient was immobile a bit. That leads to probable DVT and then PE. So because the blood pressure is low, it should be either moderate or severe pulmonary embolism. And you have RBB, sinus tachycardia, S1, Q3, T3, that kind of appearance. You have RV strain. So this patient should ideally be thrombolized because hemodynamically unstable. But the important thing is to catch the clinical picture of embolism. This is a real ECG. This is from my foreign training database. It's one of the ECGs from UK. Moving to the next slide. Right. 34-year-old, 35-year-old. He doesn't have any symptoms. This is the ECG done on routine medical screen. And it's been referred by general practitioners because it looks rather abnormal. What is your diagnosis?
One answer is sinus arrhythmia, other answer is dextrocardia.
Very good. So this is a ECG that you should not miss. This is one reason I told you in the first slide how to apply the leads correctly. So there are two dextrocardias. One is true dextrocardia. That means the heart apex is on the right side. The other is a technical dextrocardia where we the heart is on the left side, but we make it right-sided on the ECG by applying the limb leads wrong. So the giveaway clue here is AVR, the P, QRS, the T wave, all in AVR is positive in a dextrocardia. In a normal patient, just see on the ECG, those are negative. And there is something called V1 to V6 R wave progression, which is absent in a true dextrocardia. But as you all know, in a technical dextrocardia, the R wave progression is present, but this part remains the same. You're clear, Suku?
Yes, sir.
Good. Next slide. A 45-year-old coming with atypical chest pain. Now, we saw a similar ECG for myocarditis. Can you remember perimyocarditis?
Yes, sir.
So, this patient comes with similar chest pain and a similar ECG. What is the difference? So, this is what we call BER, benign early repolarization. So, people have difficulty in distinguishing with ST elevation or myocarditis. But the classical giveaway is this fish hook appearance. Can you see a notch? We call it a J wave. So when you see a J wave and you see a higher ST segment, it appears like pericarditis. But this fish hook appearance gives the way for a diagnosis of early repolarization. So this is the diagrammatic illustration. There are other ways to differentiate pericarditis ECG from benign repolarization. But just if you can remember the fish hook pattern, that is more than enough for today. "67-year-old past breast carcinoma," sorry for the spelling mistake, breast carcinoma 5 years ago, comes with a bit of chest pain and dependent edema. What is your diagnosis? You have to think of the background history and then come to diagnosis.
Pericardial effusion is one answer, sir.
Yeah, excellent. So, with the history of malignancy, there could be malignant collections, and the main point here is that there is ECG alterance. Can you see the amplitude of the QRS complex changes? Because the distance from the chest wall to the heart surface changes from beat to beat because of the pericardial collection. So there is low voltage complexes and electrical alterance. Moving to the next. Right, this is another ECG from UK. So this patient, 74-year-old lady who is living alone, who celebrated her 74th birthday yesterday with gathering of so many close relatives. Next day comes with feeling dizzy and chest pain and this ECG. Any suggestions?
Late presentation of inferior MI.
Yeah,
Inferior.
it's a bit of a tricky case. If you can see, this is one of the ACS mimics. So there seems to be a ST elevation on the inferior leads, but there seems to be Q waves in V1 to V4 also.
Hypokalemia is another answer.
Yeah.
Takotsuko.
So if you can see, there are very broad T waves which fulfill long QT criteria. Hope you all agree that there is a long QT. QT is measured here, 474. So in ladies, more than 460. But with the history I gave, it's broken heart syndrome. Classically, it happens with a sad situation. But there is something called happy heart syndrome. So it can happen for a special incidence, emotionally of value to you, which has a sadness or a happiness. So that's due to catecholamine surge, and it's Takotsubo. So if you see this type of diffuse T inversions with long QT and a background history of recent event, then suspect that it will be confirmed on the echo. Good. Next slide. 75-year-old coming with acute confusion, hemiplegia, chest pain, and a low blood pressure. So there is inferior ST elevation. So there is an inferior STEMI. But in addition, he has neurological symptoms and low blood pressure. What do you think is the diagnosis? Till no one has answered, isn't it, Supun?
No, sir. This time, no answers yet.
The first time I go answerless.
Aortic dissection?
Wow, very good. All right. So the take-home point: when you have acute coronary event along with neurological symptoms, always think of aortic dissection. The other way is if you create a anterior STEMI which causes mural thrombus, then embolizes causing a stroke, then still this can happen, but it's a long shot. So the classical presentation is both happening at the same time. So chest pain as well as the neurology happens the same time. But on the other scenario where there is anterior STEMI, EF drop, then forming a clot, then clot getting embolized, it takes a bit of time. So if you thrombolize this patient, it will be disastrous. Hope you agree, because there is a dissection and you would exaggerate the dissection and create more problems if you thrombolize. So diagnosis is of paramount importance. Next slide. So the way to go is CT brain and thorax and await results to decide on thrombolysis. 60-year-old patient, diabetic, acute SOB and chest pain for 2 hours. I would go through this ECG. There is no catch in this. But this is what we call AVR ST elevation. Have you heard of it? Supun?
No, sir. I haven't heard.
Yeah,
about
so
that.
one of the types of ST elevations, we discuss inferior, anterior, lateral. Here the ST elevation is AVR and all else is ST depression. So this is common to 3 scenarios. One is a tight left main disease. The other is a tight ostial LAD. Third is diffuse hypoxia. So even for some lung cause patient goes hypoxic, he can have this ECG without primary cardiac problem. So it does not mean the patient has coronary issue. That's why the guideline does not suggest to thrombolize or to activate a primary PCI for a AVR STEMI. But I have seen so many consultants thrombolize AVR STEMI. So the ideal way is low molecular weight heparin and then go for early angio. Last case, 65-year-old with past ST elevation MI comes with faintishness and this ECG. What's your diagnosis?
VT, ventricular tachycardias, is the commonest answer.
Yeah, perfect. So with the background history, it's most likely that it's a VT. But I'm sure you know the dilemma as well as the differentiating features of SVT bundle branch block from a VT. So I would not go through all those details, but I would tell the 2 clues that I use to differentiate. So first thing I check is the axis. If the AVR is up, that means we call northwest axis, northwest. That's 99% of the time VT. Second is, if you see a capture fusion beats, can you see in this here, you have a P dissociation. A P can be seen here clear on the rhythm string. So that's a capture, a dissociated P. So if you see capture fusion beats, that's a diagnostic hallmark. The other is AVR. So look at those two. In addition, there are other features like concordance, Brugada sign, rabbit tears, various things. But with the given history, it's very likely that it's a VT. So never hesitate to give a DC shock when you come across these patients. Whatever the diagnosis of the arrhythmia, if patient's hemodynamically unstable, the first treatment is shock. Not trying to pull your hair or thinking what's the diagnosis. Right, thank you. So sorry for the technical mishaps. So I cost it 20 minutes probably. But I have arranged 3 MCQs for the feedback which I have sent to Prabhat. And again, my thanks to all you have stayed late till night, more than 150, for listening to this rubbish. All right, thank you.
Thank you so much sir, for your time, even with your busy schedule, for giving us time. And am I right if I say that you are the only person in Sri Lanka with interventional cardiology plus cardiac electrophysiology experience, sir?
As for the training, yes, but we have to select one for the board certification. So I have selected intervention cardiology.
So we were so lucky to have a session like this with you, sir. And thank you so much for giving us your time and valuable knowledge, for sharing your valuable knowledge with us. And I thank Dr. Prabhat also for arranging this session. So in the chat box, if you see, all have thanked you. Since this was an interactive session, I think their questions were answered then and there. So if there are any other questions, we would reach you through Dr. Prabhat, sir.
Perfect. All right.
Thank you so much, sir. So we'll call it a day.